Hello, everyone. My name is Caroyn Oxencis. I'm excited to be here today presenting with my colleague Emili Leary on the topic of pharmacogenomics. Today we will be presenting Making the Case, Implementing Pharmacogenetic Clinical Services. I am a pharmacogenomics clinical pharmacist at Freighter Health System. I'm in the Medical College of Wisconsin, and Emili is a research clinical and outpatient pharmacist at the Marshfield Clinical Research Institute and Health System. So without further ado, we do not have any relevant financial relationships to disclose, but for your information, part of Emili's content was developed for the Marshfield Clinical Pharmacogenomics Certificate Program, and she does have some grant support for her efforts at her institution. Our learning objectives today are as follows. After our program, which we're excited to offer for both pharmacist and pharmacy technician CE, we hope that you can define pharmacogenetics and outline the applications to clinical practice, describe the role of the pharmacist, identify opportunities and challenges when you're creating a pharmacogenetic practice model, and we're going to share some key components for successful implementation. So we're hoping that you can list those as part of a potentially successful pharmacogenetics consult service at your institution. So what is pharmacogenetics? We are going to go through some background and definitions to level set and make sure that we start off on the same foot. So pharmacogenetics is often abbreviated as PGX. So you will hear me refer to that acronym and see it on slides. And pharmacogenetics is using an individual's genetic information to predict response to medication. So this type of testing helps us determine what drugs and what doses are safe for patients and which ones to avoid based on their individual genetic information. The way I like to describe pharmacogenetics is precision medicine for medications. Precision medicine is a buzzword you often hear, and that can apply to many things, but it really is transitioning from a one-size-fits-all type of prescribing pattern to personalized prescribing. So with that genetic information, through this illustration here, you can see we can really determine and guess, make a best guess about which drug might work the best for patients and avoid adverse effects of medications. There are many different ways that genetic variations can impact drug response. These include what's on the slide, but it's definitely not limited to our pharmacokinetic and pharmacodynamic aspects of drug metabolism and action. So you'll see a lot of familiar things as you've learned about drugs in practice as a pharmacist or even dispense drugs. But these are what we've discovered influence the body's DNA and effect on medication. So you can see absorption, distribution, metabolism. Metabolism is a big one. Those are CYP450 enzymes in our liver. And then we also have drug transporters that can also play a role in how our body processes and uses medications. And as we move forward through the presentation, you'll hear me say pharmacogenetics and pharmacogenomics. There is a slight difference in the definition. Pharmacogenetics refers to that single gene and that PK/PD pathway, and pharmacogenomics refers to all the omics. So you can see other omics along with genomics, such as transcriptomics, et cetera. But we really do use these terms interchangeably in clinical practice and throughout the presentation. So how do we apply pharmacogenetics to our clinical practice? Another way to frame pharmacogenomics when you're sharing how it plays in with providers or with administrators is within the lens of adverse drug reactions. So adverse drug events are one of the top 4 leading causes of death in the United States. And every 2 minutes, a life is lost due to non-optimized medication. So adverse events really are important, not only for patient care, but our role as a pharmacist. Within this room that we're presenting in today, over 90% of you will have a genetic variant impacting medication response. So this is really prevalent. And we have support from the FDA saying that drug-gene interactions should be considered similar in scope to drug-drug interactions. So I encourage all of you here and listening to add that to your patient profile review process, add that to those patient cases. Look for drug-drug interactions, but also consider those drug-gene interactions. That's something that we need to embrace fully as pharmacists. Here are some additional facts and figures on the impact of pharmacogenetics. So again, the majority of us in this room have a variant that could affect drug metabolism. And around 40% of the most commonly prescribed drugs have a drug-gene interaction. So when you look at those facts and figures, top 10 drugs prescribed in North America, top 200 drugs that perhaps our pharmacy students are learning, a large proportion of those have drug-gene implications. And up to half of Americans are taking a medication, which is included in a pharmacogenetic guideline. We do have some great guidelines in place that don't tell us when to test, but they do tell us what to do with test results. And we'll talk about those as well in our presentation. Cost savings is also something important to consider. So pharmacogenomics has been shown to reduce hospitalizations and emergency department visits. This is good for patients as far as their healthcare, and it's also good for reducing costs. We see improved medication adherence when pharmacogenetics is applied. So the more patients know and understand about their medications, I think the more comfortable they feel taking them. And also, if you can tailor their medication list to avoid those adverse effects that might prevent them from wanting to take the medication regularly, they'll be more adherent. There are also some patient impression and patient feeling studies around pharmacogenetic testing showing that it increases patient trust and confidence with the healthcare team. So really a great opportunity to partner with patients and provide that individualized care. And again, you'll see in various groups, oncology is an example, also mental health, where different patient populations and drug gene pairs have been shown to have pharmacogenetic testing associated with cost savings or cost effectiveness. So as you decide where you might implement or what group to work with in your health system, really digging into the literature and seeing what is out there for that drug gene pair as far as cost savings can be helpful to you. So this leads us to learning assessment 1. Which of the following matches the correct definition of pharmacogenetics? A, dedication to patient safety policies and protocols to reduce the risk of harm. B, decreasing the spread of infection by multi-drug resistant organisms. C, the study of the role of the genome in drug response. Or D, rational prescribing of opioids to optimize pain management. So the answer is C, the study of the role of the genome in drug response. You can see I gave a shout out to some of the other important roles that pharmacists can hold, including medication safety officer, antimicrobial stewardship, pain management or pain stewardship. But C would be the correct as far as what is pharmacogenetics. What are the roles and responsibilities of the pharmacist? When it relates to pharmacogenetics, you might be sitting here thinking, well, this sounds great, but what do I have to do with it? And the answer is quite a lot. As part of the pharmacy team, as the pharmacist, as the pharmacy resident, student, or the technician, we do put the pharm in pharmacogenomics. So this is an excerpt from the ASHP statement on the role of the pharmacist in pharmacogenomics. And because of our knowledge, skills, abilities, we are the ones who are positioned to lead this effort to develop processes for ordering the tests, reporting out pharmacogenetic test results, and also interpreting test results. So this is something that all pharmacists should strive to be comfortable with. So hopefully if you're listening and you are not, this will encourage you to do a little more digging into this topic. And we are the medication experts. We're one of the most trusted healthcare professionals, and we are part of the team that is helping to guide drug selection and drug dosing. And this goes hand in hand with pharmacogenetics. That is what the information that it provides is what allows us to further do that for patients. So just to conclude and highlight a few of the roles and responsibilities, and again, this is highlights. I really encourage you all to pull this reference and use it for topic discussion or become familiar. So as far as the roles, designing those patient-specific drug regimens based on a pharmacogenomic profile and communicating those results to the healthcare team, and also patient and provider education. We use a lot of big words and complicated words. So practicing how you communicate to providers and patients regarding genetic testing is also very important. And our responsibilities, we should be advocating for pharmacogenetic testing where it's appropriate. And we should feel comfortable ordering those tests, interpreting, and optimizing medication therapy based on those results. Myself, I am a trained oncology pharmacist, so there are additional roles and responsibilities in this position statement for those of you who might practice in oncology and also who have moved into pharmacogenetic specific roles, such as Emily and myself. What are some challenges and opportunities as we look at what a practice model would look like? Some challenges include defining the scope of your service within a system. There are a whole variety of drug gene pairs, over 20 with CPIC guidelines, and it can be hard to choose, where are you going to start? So many institutions and fellow implementers have chosen to start with a single drug gene pair. And some start with a panel, so something to think about. And what is your technology that you have available? Ideally, we would want those results to be reported back easily within our electronic health record and integrated into the system. We do need to consider consent, ethics, and compliance. This is a genetic test, and right now we don't have good guidelines on what the standards should be for consent. So leaning on your legal and ethics team to see what would be the best process. And then also funding. Deciding on whether you will have dedicated pharmacists focusing on pharmacogenetics or if this would be more of a shared team role. And the opportunities, I think that we've touched on already, really the goal of preventing adverse drug events for our patients, decreasing those admissions and visits to the emergency room, and overall improving health outcomes really is the goal and the driver of this. And then also improving adherence and patient satisfaction. So those are the opportunities, and I think that they're great ones that resonate with all of us as patient care providers, and will also resonate with leadership at your health systems. So that segues into our learning assessment 2. Which of the following statements is accurate regarding the role of the pharmacist in pharmacogenetics? A, medication inventory and coordinating drug transportation. B, optimizing medication therapy based on genetic test results. C, preparing infusions and performing product verification. Or D, pharmacists have no role in pharmacogenetics. So I hope no one chose D. The correct answer is B, optimizing medication therapy based on genetic test results. A and C are very important roles that pharmacists take on, both from medication utilization standpoints and working in the infusion and central pharmacies, but B is the correct answer.
Thank you so much, Carrie. That was a great overview. So my name is Emili Leary, and I am jumping in to talk about pharmacogenetics and implementation. I'm going to be covering these considerations, and these are summarized very nicely in an article by Sakali et al. 2022, How to Implement a Pharmacogenetic Service at Your Institution. And I really love this paper because I feel like it does a lovely job at really covering all the main bases. So with that, let's get going. First, I'd like to talk about stakeholders and engagement. This is important because without support, you're not going to be able to get your pharmacogenomics program off the ground. It's helpful when your pharmacogenetics implementation initiative aligns with institutional mission, values, and strategic goals. It's important also to consider who your leadership is going to be for implementation. And as Carrie had mentioned, pharmacists are really poised to lead these type of initiatives. But you will require help from other friends, including your friends in safety, ethics, and compliance, information technology, laboratory services, and many other stakeholders. Additionally, I know we all don't love talking about funding, but funding is going to be critical for your program. There are a lot of considerations for costs associated with offering a pharmacogenomics program. And so you do have to be mindful. We all have to be good stewards of resource dollars. And you also will want to get endorsements again from that leadership. So these are some important considerations when you're considering starting your own pharmacogenomics program. The next thing you want to consider is evidence and actionability. And I feel like this is really, really important because our goal is to provide accurate, consistent, and reliable pharmacogenomic result interpretation. So one of your first questions are going to be, what will be your criteria for actionability of results? There are a number of pharmacogenetic testing companies that offer proprietary algorithms to make medication recommendations. However, these are not always in line with the FDA, CPIC, and other pharmacogenetic leadership groups. So you do want to be very mindful of what your actionability for results will be. Additionally, when you are providing medication recommendations based upon pharmacogenomic results, you want to make sure that everybody in your organization and your team will be on the same page regarding what they will recommend. So again, this kind of goes back to what will you define as your actionability for results? And by actionability, I mean, what criteria will you actually rely on to make medication changes? All of this should really be an institutional decision based upon scientific, non-biased, and evidence-based information. And I will cover some important resources momentarily to help you determine those criteria for actionability. At Marshfield Clinic, we actually follow the criteria of number one, does the drug gene pair have a CPIC guideline? Are there recommendations on the FDA table of pharmacogenetic associations in sections 1 and 2 for a drug gene association that warrants a potential change in medication therapy? And then our third criteria at Marshfield Clinic is there a significant safety concern? And factor V Leiden is always the one that I tend to call upon. So we determined that after our review of these particular resources, and as a group, we decided that we wanted to adhere to those three criteria. The resources that I just mentioned are listed here. So resource number one is CPIC. This is the Clinical Pharmacogenetic Implementation Consortium, and they are a large group of experts in the field who do offer guidelines and implementation resources. They also propose drug gene pairs and kind of have a upcoming list that can be worked on by interested experts. And then you can also become a member of CPIC to help with their initiatives. And they do adhere to the Institute of Medicine's criteria for creating high quality clinical practice guidelines based upon a very thorough review. They do offer these guidelines for free, and they do have an extensive disclosure for their authorship of those guidelines. So CPIC is a very reliable and well-respected group within the pharmacogenomics community. The next resource that I'd like to highlight, the FDA actually offers a couple of resources in the way of pharmacogenomics, and what I've personally found is the biomarker table and the pharmacogenetics, excuse me, table of associations. For me personally, I found the biomarker table to be a little bit more pertinent to oncology uses, whereas for more germline uses and what we more commonly see in my practice, the FDA's Pharmacogenetics Associations table tends to be a little bit more relevant. They do have 3 sections of that table, and sections 1 and 2 tend to have a little bit more support for modifying medication therapy based upon drug gene associations. The next resource I'd like to point your direction towards is the Genetic Testing Registry, GTR. This is a nice resource that can actually help you to evaluate and look at current offerings of pharmacogenetic test offerings. It is something that I would encourage you to play around with just because there are multiple filters. But we do have the link out on this slide for those of you who have the slide set, so you can kind of poke around there and see what you can see. The next resource I'd like to highlight is PharmGKB. This is the pharmacogenetics knowledge base. And really, this is one of my favorite resources. It's really a one-stop shop for all things pharmacogenetics. They do host the CPIC guidelines as well as several other professional guidelines like the Dutch Pharmacogenetics Working Group, DPWG, also the Canadian guidelines and the French guidelines as well. They do have a search bar that is super helpful for learning more about drugs, genes, variants, and basically anything you'd want to know about pharmacogenetics. Their homepage does offer a tour, which I would highly encourage you to take just because there are so many little goodies that are hidden throughout PharmGKB. So I would encourage you to also poke around that website as it is a gold mine for all things pharmacogenetics. The last resource that I have listed here on this table is PharmVar. And this is really helpful when you are trying to compare apples to apples when you're looking at different pharmacogenetic testing companies. PharmVar is a repository for defining the alleles within pharmacogenetic genes. They also do have various nomenclature resources as well as other resources. And again, this is a really great resource to kind of be able to compare apples to apples when you're looking at the variants offered by different pharmacogenetic testing companies, simply because different pharmacogenetic testing companies will use different nomenclature to share what variants they do test for within a gene. And so PharmVar is one of the resources we can use to ensure that we are talking apples to apples. Lastly, I do want to put a little plug out there. PSW has published the PGX toolkit from last year, so that is another great resource for all of you. The next implementation consideration is probably one of the most involved. This would be the logistics of implementation. So the first question you should also be asking yourself when you get to this is, what patient populations and disease focuses will you serve? And what I mean by this is it will be helpful to know what the majority of your population ancestry base is, because there are some important considerations with implementing pharmacogenetics, and you want to ensure that the testing that you implement is going to serve your population well. Additionally, there are certain disease focuses that do have a little bit more in the way of pharmacogenetic associations. Currently, the disease focuses that have the most evidence and the most recommendations for pharmacogenetic implementation, I would argue, would be psychiatry, as there are many SSRI and other psychiatry medication guidelines offered by CPIC. And the other area would be cardiology, just because we do have both statin guidelines by CPIC as well as clopidogrel guidelines offered by CPIC, and those can be really impactful ways to start a pharmacogenetic service. The next consideration will be, what pharmacogenetic testing company will you use and what do they cover? Now, a lot of implementers would love to do an in-house offering for pharmacogenetic testing. However, There are many barriers to starting your own testing service, in as much as like testing the DNA on site. So an in-house lab is usually not something that's immediately feasible with pharmacogenetic offerings. So you will need to use that genetic testing registry website to be able to look at what companies offer pharmacogenetic testing and what they do cover as far as both genes and alleles. Who will be directing the pharmacogenetic testing process? Again, as Carrie mentioned, pharmacists are very well poised to lead these efforts. We are the medication experts, and we can be further trained in genetics and become the leaders for these type of initiatives. Another thing that you need to consider with logistics is what will your workflow process be for testing, reporting, and billing? And this is a very exhaustive and worthwhile endeavor to try to optimize, because this will really make or break your service. You need to make sure that you're trying to develop a workflow that will be easy for people to follow, so nobody falls through the cracks, and such that it is as efficient as you possibly can make it. I'll cover billing a little bit more in just a moment. Another important consideration for logistics, and something I've really come to appreciate, is this is definitely a team-based effort, and you need to make friends in basically all areas of your organization. So not only do you need your stakeholders and your leadership to support your initiative, you also need a lot of friends in laboratory, in information technology, in the actual clinics, your clinicians. You need them to support your offerings and be willing to offer it to their patients, as well as actually utilize those test results when they do come back. So you need a whole team to accomplish this, and kind of being mindful of who you will want to reach out to try to help support this initiative will be important. As Carrie mentioned, the area of informed consent for pharmacogenetic testing is still a heavy area of research, and there are no consensus guidelines at this time. But some kind of quick things that you can think about when you are trying to determine how much informed consent, or if informed consent will at all be offered. At this time, you can kind of consider whether or not you're doing a single gene. For example, many institutions have decided to start with clopidogrel and CYP2C19. And as that is a single drug gene pair, and there are no secondary findings, meaning no health implications of genotyping CYP2C19, a lot of organizations have rationalized that informed consent would not be needed for a single drug gene pair when there are no secondary findings. That being said, if you're doing a full panel of genes, a lot of times some of those other genes will have health implications to testing that, thereby implying secondary findings. And so for the vast majority of institutions who are doing pharmacogenetic testing at this time, I believe a lot of them are doing some degree of informed consent, just to ensure that patients are fully informed prior to receiving pharmacogenetic testing. I will also put in a plug. This is a great area for you to become buddies with genetic counselors and any medical geneticists or genetics professionals that might be in your organization, because for me personally, my genetic counselor team has really helped me with our program to work through some of these considerations. Additionally, you need to identify who are the provider and patient resources for help. This is important because providers will have questions about interpretation, and patients will also have questions. And again, pharmacists are really poised to be the main go-to for these particular groups, and educating them and also guiding them on how to best utilize the patient results. Speaking of results, let's get to result use and integration. Again, our goal is to provide accurate, consistent, and reliable pharmacogenetic result interpretation. So again, I'm coming back to this. What will be your criteria for actionability for medication changes? And again, you really want to make sure you are very clear on what you're using there and that everybody is going to adhere to these. That way, you're not having two different providers making different medication recommendations that are potentially at odds. Additionally, who will be the expert and resource for interpretation? Once again, pharmacists, I would argue, are probably if you only have one individual at your institution who can do this, pharmacists are best poised. Again, I do want to make a shout out to my medical genetics friends for secondary findings, just because they can be helpful in placing referrals for any additional secondary findings. Another important thing you want to consider is, are you able to integrate the results into your medical record? And when you're thinking about your information technology resources and what you can do, integrating the results into your medical record is really a great way to consistently provide medication recommendations. And by that, I want to identify that clinical decision support that can take those integrated results and push a medication recommendation to clinicians is a really great, consistent way and reliable way to provide pharmacogenetic recommendations. So if you have that capability at all, I would strongly support trying to do that. I do want to acknowledge there are some resources involved with that, just because you will have to have IT individuals funding to support it. But it really is the best way at this time to integrate pharmacogenetics. Additionally, with medical records becoming ever complex, we do want to make sure that the results will be easily found within the medical record, and that way other providers will know about and find the results. So ensuring that you, as the leader of this pharmacogenetic implementation, know where to find things and are able to guide others to those results is going to be very important. Now we get to one of the fun topics in pharmacogenetics. It's always a hot topic: billing and reimbursement considerations. One of the things in selecting a company that you want to find out is what payment options they offer and what their cost of testing are. And I'll get into what determines that momentarily, but it's all going to come down to, what can your patient afford, and is testing actually worth it for them? Because if the cost of the test is $300 and some odd dollars, and they're choosing between getting pharmacogenetic testing and, like paying for groceries, if the cost is too high for them, they're not going to benefit from pharmacogenetics because they're not going to do it. So trying to keep the patient's ability to pay in mind is really important. That how much they pay can rely upon what insurance they have. It does not always rely only on what insurance they have. There are other things that can determine patient cost. But if you do have an insurer that does at least partially cover pharmacogenetic testing, sometimes that can be helpful to bring down that cost. If that insurance company does cover pharmacogenetic testing, is there a prior authorization process? And how would that fit with testing? And again, this will kind of go back to your workflow and trying to ensure you do have a logical workflow that everybody can follow. That way you can identify where the patient is exactly in that process. Additionally, when you are selecting a testing company, many of them have patient assistance programs that can help to bring that cost of testing down. And sometimes there are important caveats to that, like income limitations, what insurance they have, etc. So being familiar with that with the testing company you select is really important. The logistics of testing can actually impact billing and reimbursement. And I bring that up because something that we may not think about: if a blood draw is required, that's going to typically incur an additional charge of phlebotomy. And so that would be another cost that you may not immediately think of, but that you should consider when you are designing your implementation program. And lastly, this is kind of, again, something that you may not initially think about, but what billing model does your institution have? This is important because the landscape of healthcare in the United States is very complex, and there are different center types. So many large institutions that have a hospital system use provider-based billing, which I believe I talk about in one of the next slides. Others are rural medical centers that have a different billing model. And then there are also private practice institutions, as well as other types of billing models of various institutions and clinics. So some of the things that kind of go into determining what the actual cost of pharmacogenetic testing are include two different things: pharmacogenetic technology, as well as those institution considerations and patient assistance programs. So when we talk about pharmacogenetic technology, we do know that sequencing tends to be more expensive. Single and targeted gene analysis at between I'd say these prices are accurate as of around 2019. For single and targeted gene analysis, you're looking at probably $200 to $400 cost of actually analyzing that DNA. For whole exome, you're looking between 350 to over 1,000. And whole exome is basically looking at the coding parts of the DNA, the sections that we know are associated with a particular gene. So you might be missing those intronic regions and other regulatory regions of the DNA. But that being said, sequencing tends to be more expensive, just because with sequencing, you're looking at every spot along the DNA, whereas with genotyping, you're just looking at specific spots in the DNA. Whole genome sequencing is looking at everything. And right now that's not commonly done because the cost is not only very, very high, between $1,500 to upwards of 5,000, but also you generate a ton of data that the storage and querying of that data is an additional cost that can be prohibitively expensive. So I mentioned genotyping, and again, genotyping versus sequencing. Sequencing, you're looking at every nucleotide in the region that you are querying, whereas with genotyping, you're only looking at specific nucleotides that we know tend to be more variable. So you're probing the DNA, and that's a lot cheaper. And so the costs usually range between $200 to $400 for over 20 genes. So that's one component of what goes into how much pharmacogenetic testing costs. Again, there are these other considerations, the healthcare institution. And so again, depending upon your healthcare institution, if you are at a location that utilizes something like provider-based billing, and that healthcare institution bills the patient's insurance for pharmacogenetic testing, this can be quite expensive. And that's because how institutions bill insurance depends upon many factors, and frequently on how many CPT codes are used to bill. So that can be very, very expensive. Another option is if you can have that pharmacogenetic testing vendor actually bill the patient's insurance. So whatever testing company you decide, bill the patient's insurance. A lot of times this does result in a lesser cost for the patient. Typically, we do find that the cost is less than $350. And many of those testing vendors do have a patient assistance program to help bring that cost down even further. Now, another third option that is available with many vendors is direct patient pay. And so with this option, the patient says, you know what, I don't want you to bill my insurance. I just want to pay directly for the cost. And depending upon which company, those costs can be closer to the $260+ range. So again, really knowing your what company or vendor you're going to be using, how your healthcare institution, what their billing practices are, and then, the methodology used. A lot of those things will go into the billing and reimbursement for pharmacogenetic testing. So some key pearls: know the billing process of the pharmacogenetic testing company and your institution. It is, again, you need to make friends in your billing department to really understand your institution's billing process. This is a complex area that is very rapidly evolving. So if you want to learn more, one good way to kind of stay up to date is to check out the American Society of Pharmacovigilance, their STRIPE initiative, Standardizing Laboratory Practices in Pharmacogenomics. And that their goal is really to try to standardize laboratory practices and billing practices in pharmacogenomics. So that's a good resource to check out. Education is the next area of an implementation service. And again, pharmacists really play an integral role in the pharmacogenetic education. I've said this a couple times. I do want to acknowledge my medical genetics professional buddies because they're very valuable for laboratory and sometimes even like talking about pharmacogenetics as pharmacists. We counsel all the time on medications, but when you talk about DNA, you find very quickly that it's a little bit different vocabulary that you will use with your patients. And in my experience, my medical genetic buddies have given me some very good pearls for talking about DNA and results. But again, pharmacists are really going to be the leaders in this. And so you are going to be the main individuals who are going to be educating patients, your peers, the providers, your stakeholders, because again, you need to advocate for your implementation program, and then your supporting team. So, you know, you're going to be buddying with your friends in IT. And while they are really focused on trying to get you what you want, you do have to do a little bit of education to help them understand what the goal is. Once you start the program, or even when you're setting up the program, you do need to make sure that this is going to be something that is sustainable. A great iterative process for improving your program is going to be the Plan, Do, Study, Act PDSA model, where you are consistently reevaluating what you're doing, seeing how things go, and revising. Tracking metrics can be helpful, and the article does go into different metrics that you can track and how to do that. Really, our goals of this are value, scalability, and reproducibility, as well as sustainability. And a quote that is actually out of Silicon Valley and is more pertinent to informatics, but I really love for pharmacogenetics, is building the plane while flying is neither easy nor free. So that just kind of speaks to, you know, you're on the cutting edge of medical care. And so again, just revising and making sure that your program is as healthy as it can be and as efficient as it can be is important, but just know that there will be significant effort associated with doing that. So this brings us to learning assessment number 3. Which of the following information technology resources should be determined when building a pharmacogenetic clinical practice model? Is it A, patient population to target for genetic testing? Is it B, drug gene pairs for implementation? Is it C, reference laboratory testing platform? Or is it D, available clinical decision support tool functionality? So the answer is D, because the question is specifically asking about information technology resources. And while those other answers are very important for determining and building a pharmacogenetic clinical practice model, when we're thinking about our information technology, again, clinical decision support and integrating your results into the medical record is a really important and high quality way to implement pharmacogenetics. And so if you're able to do that, it's strongly recommended to do that. Here at Marshfield Clinic, like I mentioned, we have implemented pharmacogenetics. So I'm going to kind of take a few minutes to cover what we have done. We have been able to implement the pharmacogenetics into the medical record. So we were lucky in as much as pharmacogenetics started as several research initiatives, and that can be really helpful because you can get seed money out of research initiatives to kind of start some of these implementation programs. We did have some unique features of our organization that did help facilitate implementation. Initially, we were on our own homegrown electronic medical record. Later, we did transition to Cerner, the commercial medical record, as the alert shows here. However, we did start off with our own homegrown medical record, which did allow us to be able to very carefully design and implement alerts. Marshfield Clinic also has a very robust information technology center as well as personnel. And the Research Institute has very, very strong resources and focus on genetics, which really help to push pharmacogenetics as an initiative. And then additionally, we also have very passionate stakeholder leaders as well as donor support. And again, we were able to integrate pharmacogenetics into our medical record. We chose to integrate into our laboratory area. There are a few different places that you can integrate within medical records, and the lab area happens to be what we chose. So with this particular alert, which is already outdated and we have already revised, I just don't have a more current picture of it. But this is an example of what would pop up if the clinician went to prescribe escitalopram for a patient who was a CYP2C19 rapid metabolizer. So when we decided we wanted to do pharmacogenetic implementation, we did have to develop an interprofessional team to accomplish this, comprised of all the stakeholders as listed here. We did develop 2 committees to govern and implement pharmacogenetic initiatives. Our approving body is the Pharmacogenetics Subcommittee, PGSC, which is a subcommittee of our safety committee. And then we also have our Clinical Decision Support Work Group, CDSW, which are kind of like the ground troops for pharmacogenetic implementation. We have developed a referral process that is housed out of our clinical pharmacy services. And so this is kind of our funneling mechanism to funnel all pharmacogenetic referrals to one central location. That way we can have a very precise mechanism for bringing patients from beginning to end of the process. So, sorry. Okay, sorry, my animations got a little out of order. So for the details, we do have a process that's informed and refined by informatics, laboratory, medical genetics, and pharmacy stakeholders. We do have 2 preferred external vendors for testing at Marshfield Clinic. For billing, we do utilize provider-based billing, which again is a hospital and clinic model for billing and necessitates certain billing requirements, which has kind of determined how and where we collect patient samples. Based upon this, to make it the most cost efficient for patients, we do have at-home sample collection instead of on-site. Our staff is a primary pharmacist myself, and so I functionally dedicate about 0.1 FTE to this pharmacogenetic service, and there, we do have 2 backup pharmacists to support the service. And so the patient process is really, we do a pre-test consultation and documentation. They get tested, and then we have a post-test consult, which is optional for the patient. It's at the patient or provider request. And then the results are directly shared with the patient in a letter. And in that letter, they also are very overtly directed to call me to do a post-test consultation if they would like. We do have the results integrated into our medical record, as I mentioned. We do have some discrete results, which do generate those pop-up alerts, but we also integrate the full PDF as a scanned document into our medical record. And the process goes referral is placed by either the patient or the provider. We do a pre-consultation with the patient and confirm with the provider that the order is approved. We place the order, our laboratory takes over and does all the magic behind the scenes. The patient completes the testing and sends it to the testing company. Those results are uploaded and integrated into our medical record. And then we have a post-consultation as well as a post-testing document that kind of gives providers the heads up as to where the results are stored and what are some key takeaways of those results. So we do have, in the context of that article by Sakali et al. 2022, I do have listed here how our efforts do align with the recommendations in that paper, which I won't belabor you by reading through this. So these are some examples that you can read through at your own leisure. And with that, I'd like to turn it back over to Carrie.
Thank you so much, Emily. I love learning from other institutions, how they're implementing. So I also hope that the Freighter and MCW implementation story can be helpful to you all. We are very much a starting at step 0. We built this from grassroots all the way from the ground. So We actually were one of the inaugural cohorts in the ASHP Pharmacogenomics Accelerator program this year, which was put on by ASHP in conjunction with the University of Minnesota College of Pharmacy. And so really that provided a year-long framework that we just wrapped up to help us build out our clinical service. And a lot of the initial stages were spent planning and gathering those key stakeholders, really investigating who might be our leadership champion, who might be our physician champion, and how would we be really innovative and creative, and also link to our own institution's mission, vision, and strategic priorities. And that has been very helpful as a starting point for us to ensure that as we build out our program and think about what it could look like for future state, to make sure that we're keeping the patient at the forefront, and also where our institution sees itself in 2025 and beyond. So we had a great framework to build our team and start planning out what our pharmacogenomic service would look like. What we ended up doing was a population health design for our clinic, which means that we are doing targeted outreach to a specific subset of patients. So what we do is we work from a patient list that we have pulled every month, and if they meet inclusion criteria for our service, then we reach out to the physician and then reach out to the patient. Our clinic is offered Monday through Friday with 2 pharmacogenomics pharmacists staffing. I am one of those. I have 0.8 of my FTE dedicated to the pharmacogenomics clinical consult service, and then the other 0.2 to the School of Pharmacy. And we are communicating via multiple ways, telephone with our patients. We're using MyChart, we're using staff messaging. I've presented multiple times to different stakeholder groups to introduce them to the program and garner support, and then also reporting out results of our pilot. We are a virtual clinic, so we did set this up with the idea of having no walls to our care, so that we could reach out to anyone throughout our health system, which covers a large area of southeastern Wisconsin. We are able to meet with patients on site at the main campus in Milwaukee if they do need us, but the majority of our clinic is done virtually via virtual visits or telephone calls. We do have a 2-visit model, which I'll go into a little bit later. And as far as clinical support and how we set up our program, we did select a single drug gene pair. So we did CYP2C19 and clopidogrel. And what we did was create a collaborative practice agreement that we took through our P&T committee structure, through the ambulatory P&T committee, which allows us to schedule our own appointments, order our own labs, provide patient education materials. Basically, once we get the sign off on that, we run the program from start to finish, which is really great because we designed it to have the pharmacist practice at top of license. And then we did create an internal clinical guideline that goes back to that fidelity of actionable results that Emily talked about as well. What is an actionable result and what will we all do? And I can share we pretty much based our internal guideline off of CPIC guidelines with some of our internal workflows. Here's a little bit of a deeper dive into our clinic model. You can see, again, on the left, we are doing a single gene test. We did set up our clinic as a reactive model, so we are not doing testing prior to patients starting clopidogrel. We are targeting patients that are new starts within the last 30 days who've had a recent percutaneous intervention, with or without stenting, and then are started on dual antiplatelet therapy, including clopidogrel. So future state, we're hoping to do preemptive in a panel, but for a pilot and just starting out our services, we did do the single drug gene pair. Uh, so our first visit, we do collect patient consent and document that and order the lab. When that lab result comes back, it is integrated into our EHR, but with minimal direction on what to do. And so that's where we come in with our clinical decision support. We do not have the automated interruptive clinical decision support built yet. Ours is manual at this point, but we are providing provider education with the test results, doing that holistic medication therapy management. And then when we return the results, we are meeting with the patient, doing that education, again, that virtual clinic model, and having any pharmacist interventions queued up and ready to go. A little bit more detail about what we are doing in each education session, because if I was a pharmacist sitting and listening to me talk, I would want to know, well, what are you doing during those visits? It's easy to say, but harder to do. And so really we modeled our education sessions based off of another implementation group that published in AJHP last year. So I really encourage you to pull this article that's referenced here. And we pretty much followed it to the letter, with the exception of adding in an extra step with making sure to prior authorize the genetic test. We found that our patients were concerned about cost of testing, which Emily covered in great detail. So we did add in that extra step. But what we do in session 1 is, modeled off of that pharmacist patient care practice model. We review the testing, we do a complete medication history and reconciliation, assess health literacy. We talk to them about genetic testing. Have you done it before? What is it? What does it mean? What do the words mean? Risks and benefits. And then if the patient does consent and is interested, then we do go ahead and order that testing and provide a follow-up plan. For our education session 2, this is what we call our return of results visit. We frame it in hopefully patient-friendly terminology that they can understand, talk about drug-gene interactions and gene-drug-drug interactions. And this article that's referenced as well has really great scripting included as far as wording and phrasing to use when talking to patients. So again, highly recommend looking into it. And again, this is when we implement any medication changes, really do that holistic review. We base education session 2 on that comprehensive medication management model. We talk about future implications of testing because, as you know, even though patients are not on a certain medication, there are other medicines metabolized by CYP2C19. So we do talk about potential things to think about if they ever did decide to start on something for mental health, or if they would get a fungal infection. We talk about potential medication changes that might need to be made, but we reassure them that we are documenting this in the chart, and hopefully the physicians will be using that when they are prescribing in the future. And then we want to make sure that the patients understand what's going on. We do a teach back method. I like to provide them with, or ask them, if you had to explain your test result in one sentence, what would you say? And then help them come up with that one-liner to say to their family or to their doctor, their primary care doctor. And then we document pretty thoroughly in the chart, and then we do have a patient education pamphlet for each different potential metabolizer for CYP2C19 and clopidogrel. Hopefully those examples were helpful. Again, happy to share any of our experiences if you'd like to reach out afterwards one-on-one and ask more specific questions, and we're happy to share what we are able to with you all. So as far as implementation pearls, really we hope that we have encouraged you all to become the expert. Take a pharmacogenomics certificate program, take a program, any program, Emily and I have both seen and been involved in and actually created modules for different programs. And really, they are all wonderful. They have different components. Some are all online, some require in-person participation. So, compare and contrast and pick the one that fits best for you. But I really encourage you to look into those programs, attend meetings, attend talks like the one that we're giving today. And really start to talk about this with your direct reports or your one-ups. Leadership support and that dedicated team are really critical to getting a pharmacogenetic consult service off the ground. Think about research initiatives. If you are at a larger medical center, see what type of grant fundings or who you can partner with. And read up. We've got a nice long list of references for some amazing nighttime bedtime reading for you. Or another trick might be have this be a topic discussion, right, with your students and residents, or even do a grand rounds. Encourage someone to stretch themselves and do a grand rounds on updates in pharmacogenetics. Make PGX friends. You have 2 new friends today, myself and Emily. We are your new buddies, and reach out to us because a lot of some of the practical ins and outs, lessons learned, they're not in the literature, and some of the frustrations, the headwinds, and the wins as well. Discussions are the best way to learn those as you go through the process. And then patience, time, and flexibility really are key. Implementation science is so fun, but you definitely go through that norming, storming, performing process. And the storming can be quite stormy. And I've been there, Emily's been there. And as we go through our PDSA cycles and try to expand and scale up our programs, we go through it all again. So please reach out. Don't hesitate, but go into this with eyes wide open as far as what might occur. In conclusion, we hope that you feel also, along with us, that pharmacogenomics initiatives should be spearheaded by pharmacists, really with the goal of promoting that safe, effective, and cost-efficient medication use. And that we really should be spearheading and the point for education efforts for our peers, for our patients, and also for the entire interprofessional team. So to wrap it up, we have learning assessment 4. Which of the following is most likely to positively influence piloting a pharmacogenetic consult service? A, institutional leadership support and a provider champion. B, which pharmacogenomic certificate program pharmacist staff complete. C, participation in a clinical trial and banking research genomic data. Or D, hiring an external consult service to launch a pilot service. All right, and the answer is A. So really finding that leadership support, finding your champion, linking your service to mission, vision, goals will really help you get off the ground. Again, take a certificate, any certificate. Research is a great way to get funding, but if you are working somewhere where that's not an option, you can still do this. And it is an option to hire an external consult service. There are other large health systems who have done this. There are other implementers who have gone on to provide this service. My institution went with a formal accelerator program, but you can also do this by yourself using your resources and framework. But A is the best choice for this one. And with that, we'll take any questions. Again, please don't hesitate to reach out to us. We have our email contacts here. Happy to chat and share. And again, another plug for the PSW Pharmacogenetics Toolkit, which is available on the PSW website. And Emily is also a co-author of. And it's a great resource. It's really a nice one-stop shop if you'd like to use that as a springboard to get started. And Emily and I also participate in and lead a pharmacogenetics and pharmacogenomics interest group. So look out for those registrations and assignments, and everyone is welcome. Come one, come all. Send your students, send your residents, anyone who's interested in talking pharmacogenetics with us. Here are our references, and here is your CE code today to get credit. N as in Nancy, 8Y, C as in 2 carries, 9. Thank you all for joining us. We really appreciate it. We hope you learned a lot, and we hope that we've inspired you all to be passionate about pharmacogenetics.